Good afternoon. Yeah, you can listen to me. Okay. First of all, I would like to thank KSM and College of Pulmonologists for organizing this session as well as inviting me to deliver a lecture. So, what you want me to deliver is pediatric TB, why it is different, and it is very difficult to deliver everything about pediatric TB within 20 minutes time. So, I would rather like to discuss regarding the drug-sensitive pulmonary TB, which is the commonest form in pediatric practice. While talking about the drug-sensitive pulmonary TB, I will discuss why it is different, where it is different, and why it is different. So, as you all know, pulmonary tuberculosis is a bacteriologically confirmed or clinically diagnosed case of TB involving the lung parenchyma or tracheobronchial tree. Since 2020, tuberculous mediastinal and hilar lymphadenopathy in pediatric practice also classified as pulmonary TB, but not cervical. And biliary TB is also classified as pulmonary TB because it involves lung parenchyma. And TB pleural effusion is not classified as pulmonary TB unless it is involved with coexisting lung consolidations. And the basic difference in pediatric adult practice is it is very difficult to diagnose. So diagnosing pediatric pulmonary TB is challenging. That's why the low case detection rate was a major problem worldwide. And according to the literature, less than 40% of the estimated cases was notified annually worldwide, not only in Sri Lanka or India like developing countries, it's worldwide. And this is worst among the children below 5 years of age. The detection rate is, estimated detection rate is less than 30%. But unfortunately, 80% of the TB-related pediatric deaths are among this less than 5 years group. So it is a major problem because majority of the deaths are due to the undetection and not treating. And the reasons for this low case detection rate is, first of all, the paucibacillary nature of the TB disease in children. So they are not expectorating a high concentration of TB bacilli like in adult practice. And also, on the other hand, they are unable to produce a good quality sputum because of the less power of coughing. And also, we have the lack of the sensitive point of care diagnostic test because the bacillary concentration is low. And also, pediatric TB, the clinical presentation is it's not very specific. And so misdiagnosis due to the overlap of non-specific symptoms are there in pediatric practice. And on the other hand, pulmonary healthcare level has a little or sometimes no awareness about the disease as well as the capacity of diagnosis and treatment of pediatric tuberculosis. So as in adult or even more than in adult, detailed history is very important in pediatric TB diagnosis, which includes contact screening and also the clinical examination and investigations. Here I have put only 2 investigations. You will understand why I have put 2 investigations, because in pediatric TB diagnosis, now we are giving priority to chest X-ray as well as the bacterial confirmation. The rest of the investigations are not considered as important in pediatric TB diagnosis. So what are the clinical presentations of the pediatric TB? So we have signs and symptoms suggestive of TB, and when you go through the list, you can see how non-specific is that. So cough for more than 2 weeks, or weight loss, or poor weight gain, or pneumonia not responding to antibiotics, or poorly controlled asthma, or undiagnosed febrile illness more than 2 weeks, or poor feeding or anorexia. This can be happen in any disease in any kid. And when a child presents with that sort of symptoms, we have to see whether this child is having high risk to develop TB than the others. If the child had some sort of a contact with a TB patient during last 2 years, or if the child is living with HIV or living with HIV infected patient, or if the child is having severe acute malnutrition, or if the child is immunocompromised or refugee, or the child is less than 5 years who are coming from some sort of a high risk setting like highly crowded community, they are having increased risk of developing TB. So diagnostic algorithm is very important in pediatric TB. So I like to discuss 3 algorithms which we can use to diagnose TB. First of all, our national program of tuberculosis control and chest diseases, Sri Lankan guideline, Sri Lankan not guideline actually, guideline was published in 2018 and algorithm was published in 2020. So National Diagnostic Algorithm for Pediatric Tuberculosis. And the second one is NTEP Guideline India, which was published in 2022. And the third one is Integrated Treatment Decision Algorithm published by WHO during the guideline, the Pediatric TB Guideline 2022. So can you see this clearly, those who are in the back? Okay, so Pediatric TB Guidelines in Sri Lanka, if we are suspecting if you are suspecting tuberculosis clinically, then what we have to do is we have to see whether this is a pulmonary TB suspicion, is pulmonary TB or extrapulmonary TB. So I'm not going to talk about the extrapulmonary TB here. And if we are suspecting pulmonary TB, we have to see whether this child can expectorate mucus and if the cough is present. If the cough is present, then we go through this arm, and if cough is not present, we want to go through this arm. So if cough is present, what we do is we do chest X-ray and sputum for gene expert or expert MTBRIF. And if possible, and if we have enough sample, we will do the sputum culture. And then if gene expert is positive, and if the chest X-ray is positive, we consider this as TB. And if the gene expert positive, even though the X-ray is negative, we still consider as diagnosed TB, confirmed TB. And if child cannot produce sputum, then we have to admit the child and do the chest X-ray, and we should go for the other respiratory sampling, that is induced sputum, or sometimes we have to go gastric aspiration, or we have to do some, sometimes we have to do the bronchoscopy sampling, tracheal aspiration, or that sort of thing. And also these samples also process as the same. And if the expert and if expert is negative and the X-ray is positive, you have gone through the lot of X-ray features, and I will discuss regarding the pediatric X-ray features also. If the expert is negative but the X-ray is positive, then we should refer the child to a specialist, either pediatric chest physician or adult chest physician, for further evaluation, which will include HRCT as well as bronchoscopy and other sort of investigations. If both is negative, then we should treat for the treat as lower respiratory tract infection or bacterial infection, and we have to reassess. And Indian guideline is also the same, with little differences are there. They do not do the X-ray and gene expert together. Instead of that, they are doing the X-ray first, and depending on the X-ray findings, they go in the same way that our algorithm has shown. But WHO guideline or WHO algorithm is a bit different, and also they have little bit low threshold to diagnose TB. I don't know whether it is very clear to you, but it is, according to my opinion, it is less practical in pediatric practice, because if in here, if all the investigations negative, but still we are clinically suspecting, they have introduced a scoring system. That scoring system has signs and symptoms as well as chest X-ray features. And if the score is more than 20, you can go through this to the WHO website. If the score is 20, then we should start treatment. So in my opinion, this may be important in the low prevalent countries than the high prevalent countries like us. Okay, so I will discuss regarding the chest X-ray some important facts about the pediatric chest X-ray and the rapid diagnostic test or microbiological confirmation. So chest X-ray is a good screening tool in pediatrics. The majority of the children with pulmonary TB is having X-ray changes, and these changes also can mimic the variety of the other diseases. So chest X-ray has a limited role in confirming the diagnosis of pulmonary TB, and also normal X-ray does not exclude the pulmonary TB. And highly suggestive features of pulmonary TB is high-low mediastinal adenopathy with persistent lung opacity or segmental lung collapse, as well as miliary pattern or chronic fibrocavitary shadows. Apart from that, if the lung opacities are not improving after appropriate antibiotic or pleural or pericardial effusion in a child who is not very sick, or dense alveolar calcification in a child who is not very ill, also we can consider as TB. Here, regarding the lung opacities, which is not improving after a course of antibiotics, so if we are suspecting TB in the background and if we have to treat the respiratory tract infection with antibiotics, the best antibiotic will be amoxicillin or coamoxiclav. Apart from that, don't go for the things like linezolid or ciprofloxacin or ofloxacin, because it has anti-TB, some anti-TB effects, so it will mask the tuberculosis diagnosis. So what are the bacteriological confirmation? What are the WHO recommended rapid diagnostic tests available, and what is the place of rapid diagnostic test in pediatric practice? So WHO now recommend molecular rapid diagnostic should replace the microscopy as the initial diagnosis of diagnostic test of TB because of the paucibacillary nature. Because even though we are practicing widely acid-fast bacilli detection, the conventional detection is not very sensitive to diagnose pediatric TB. So in our guidelines, Sri Lankan guideline, also the AFB or sputum AFB is not there as a diagnostic investigation. This rapid diagnostic test can be done in a variety of respiratory and non-respiratory samples, specimens. So what are the available rapid diagnostic tests to detect TB in pediatric practice? As you all know, I think you have already gone through these sort of investigations during previous lectures. So this is expert MTB RIF or expert ultra or TrueNut assay, which these three are available in Sri Lanka, and TB LAM test and the LF-LAM assay. The last one is actually the antigen assay. It is the only available antigen assay to diagnose TB. All the others are molecular genetic assessments of TB. So expert MTB RIF is, as we all know, cartridge-based automated test. It is a cartridge-based nucleic acid amplification test. It is something like DNA or what you say, or most of the time people request what is DNA PCR for TB. So this is a DNA PCR, and also it identifies the mycobacterium complex as well as the rifampicin resistant. It will take less than 2 hours, and expert MTB RIF with ultra assay, it's a very sensitive than the gene expert. The only thing I have to mention here is when we come across with the reports, the mycobacterium tuberculosis complex detection is trace usually comes. I think it is a headache for the clinician, because when it is trace, what to do. But according to the WHO guidelines, even though it is trace, we should consider its bacteriologically confirmed TB in pediatric practice because of the paucibacillary nature. The rest of the investigations I will skip because I don't have much time. So this is a TB LAM test, which is an immunofluorescent test, which is which can use as a screening tool in the field. And there's a lateral flow libo, LF-LAM assay. It's an antigen test which is done in urine actually. So here, acceptable samples in the pediatric practice is, as we all know, sputum, gastric acid, nasopharyngeal aspirate, and in addition to that, stool was added recently. So in a pediatric practice, we can use stool to detect DNA PCR using expert and expert ultra. And when we talk about the sensitivity is equal with the respiratory, and sensitivity specificity is almost equal with the respiratory samples. On the other hand, here the sorry, yeah here the caregiver acceptability is very high for the expected sputum as well as the stool, because all the other investigations like induced sputum, gastric aspirate, and nasopharyngeal aspirate are invasive. So this is a non-invasive method to detect with sensitivity and specificity equal to respiratory samples. So few things regarding the diagnosis of pulmonary TB in pediatric practice, management of the TB in pediatric practice. Generally speaking, treatment outcome is generally good in pediatric practice, and the drug tolerance is also good. So here in pediatric, trial of treatment, TB treatment is discouraged. So we should never start trial of anti-TB treatment to diagnose whether this is TB, and you should not discontinue the TB if you are not thinking this is TB unless you have sound alternative diagnosis. So as in adult practice, the aim is the cure the patient and prevent death and prevent relapses and decrease transmission to the community, as well as prevent emergence of drug resistance, and with a minimum drug toxicity. The drug doses are a little bit higher compared to the adult in the pediatric because the metabolism is high. And as in adult practice, we divided the treatment phase as the intensive phase as well as the continuation phase. So our conventionally, the first line treatment usually comes as the new category or the retreatment category, depending on whether the patient is new or whether the patient has previously treated. The retreatment category, previously treated patients are the patients who had relapse or treatment after failure or treatment after loss to follow up. And this is the important slide I want to show you in a pediatric TB management. WHO in 2022 suggested a short duration treatment here in a children above 3 months if they have non-severe tuberculosis. Here we have to continue intensive phase for 2 months as well as continuation phase for 2 months. And it was it was proved as non-inferior to the standard 6-month treatment during the short treatment minimal tuberculosis in children trial. And it will be implemented in Sri Lanka also soon. And yeah, so what is this non-severe tuberculosis is, if the child is having peripheral lymph node TB, if parathoracic lymph nodes are there without airway obstruction, or uncomplicated TB pleural effusion is there, or possibly non-cavitary diseases confined to the one lobe of the lung, is considered as non-severe TB. And also there's another regime is there in children about 12 years. Here it is also here. It is also 4 months treatment. It uses INAH, rifampicin, moxifloxacin, and pyrazinamide for 2 months. These are the major changes in the pediatric treatment when we compare to the adult treatment. There's an issue regarding the adding the ethambutol into the pediatric TB regimes. It was not added for long years for the children less than 5 years because of the risk of optic neuritis and irreversible hearing loss. But now it was found this particular dose, if we give correct dose only during intensive phase, it has a negligible risk. So despite of age, we can add the ethambutol if the child is having HIV or if the child is coming from a background with high prevalence of the INH resistance or HIV infection. Drug adverse effects, drug-induced liver injury is the commonest adverse effect in the pediatric practice. Here also the things are managed as in adult, not much difference. We should stop all the anti-TB drugs if the ALT level is more than 3 times the upper limit of the normal or serum bilirubin is high. And child should evaluate for the other causes of liver disease like Wilson's or other liver problems, and reintroduction should be done after normalization of the liver function. If we can't wait until normalization, if the disease is severe, we can go for the bridging treatment with less hepatotoxic drug like streptomycin, ethambutol, and ofloxacin. And the bridging period should not be continued when the calculating the total ATT. So follow-up, usually during the intensive phase, we should follow the kids 2 weekly, and during the continuation phase, we should follow monthly to assess the clinical signs, treatment adherence, and evidence of adverse effects. And we should do the weight measurement and adjust the drug doses according to the weight. Okay, thank you very much.